All right, I'm Chris Knutson. I wanted to welcome you to November 2015's EMS Medicine Live. We moved from Thanksgiving to turkey time, so you could be thankful for another episode of EML. As always, I just want to reiterate, this is a vision of ours trying to share information amongst community and academic EMS physicians. Came upon this idea. We come together for NASP once a year, and I think it's fun to talk to each other and hear what each other knows and experiences. And this is just another avenue of trying to share information with each other and share knowledge. Just so you know, 2016 schedule is coming together. We have about 5 slots left for next year. I think this year has been nice. We've had folks from across New York and Pennsylvania and kind of the mid-Atlantic states. Next year, we're getting folks from Indiana, New Mexico, Texas, and kind of more folks across the country. So I'm kind of curious how this goes next year. But if your program wants to volunteer, if you want to be involved, let me know. And we're happy to get you down for a slot. And obviously looking for board review topics, case presentations, what you've learned, or something else, which I can't think of off the top of my head. But anything good, let me know. During the presentation, we're going to mute everyone. There's just too much background noise to hear Mike or myself talking. If you need to unmute yourself to ask a question, go ahead. At the end, we'll unmute everyone for questions. You can always message EMS Medicine Live. That's my laptop next to me. And I can stop Mike or ask questions if we need to in the middle as well. I am recording this. We do post these on our webpage and our Facebook page if you want to see them later. Just Google EMS Medicine Live. We're the first 2 hits, and it's pretty easy. And, of course, questions at the end, just I'll unmute you so we ask questions. I think we're fortunate today to have Mike Dailey from Albany speaking today. He's a former EMT from New York City EMS. He is, like myself, a University of Pittsburgh grad, did his residency and EMS fellowship there. I'm going to mention with Ted. Ted Delbridge was your director?
Actually, you're giving me more credit. I did not do an EMS fellowship.
Oh, you did not? I thought you did.
I did not.
Still a Pittsburgh person. So
I'm a grandfather. I was grandfathered.
Gotcha. And now University of Albany Medical College. He's director for regional EMS efforts. And also he's been at the forefront of pre-hospital naloxone, at least in the state, if not the area, and I've been very helpful. So with that, I'm going to hand it over to Mike, and he's going to be presenting end-of-life issues in EMS.
Thanks, Chris. So oddly enough, I'm not talking about pre-hospital naloxone, which is actually kind of a surprise to me because we've done so much of it over the last few years. But it's refreshing to not talk about that topic. Basically, what we're going to talk about today is a little bit about end-of-life care. I thought what we'd start with is a general overview of some pre-hospital resuscitation concepts, just as a place to establish a little bit of groundwork, and then we'll start getting into the ideas of how things have changed with time. I'm hoping this works out well from here. Much like most of the rest of you, I have no disclosures, either financial or academic, at this point. I'm going to ask Chris to do slides for me, though.
Sure.
So we're going to start really with the idea of EMS resuscitation, where that came from, and from there, really an idea of what we should be doing for our patients. We'll talk a little bit about palliative care, hospice, and how they really apply to EMS, and really when we should consider alternative care to our standard resuscitation practices, and hopefully we'll have an opportunity to review one case as well. We'll see how that goes. Many of you I know do presentations on a regular basis. I will tell you that this is one of the only cartoons that I ever use in any of my talks where I actually have authorization from the cartoonist to use this. When Mike Peters first put this strip in the Sunday paper, I dropped him a note that day telling him that I thought this was genius for what we do. And even today when I'm doing resuscitations, there's an image in the back of my mind and I'm asking the patient not to take the martini. Got to tell you, getting a martini from a pretty girl seems like a pretty good option. But really, when we're doing CPR, we're putting death on death on pause, and we need to think about that. So very fond of that cartoon. Early EMS resuscitation, and you'll see here a picture of Jeremy Cushman taking care of patients out there on the street. The reality is that resuscitation has changed a lot over the years. But if we go back even farther than that, I think is where we really start to get an idea of when resuscitation really began. So the first known documented case of resuscitation was in about 800 BC. Elijah performed mouth-to-mouth, gave the breath of life to a child. This is documented in Kings 17:22. Frankly, this is not really peer-reviewed literature, although certainly there are many peer interpretations of how this should be considered. But it's probably the first resuscitation that we hear of. If we fast forward now about 2,000 years or so, we get to rescue societies in Europe. And if we think about those, in both cases, both the Dutch and the English societies, these were both revolving around the idea of recovery or survival of drowned persons. And I think it's profoundly important for us to realize that resuscitation really started around the idea of saving people who are drowned. And as we focus on that, drowned people really look just like us. The difference is that they were cold and they were wet. Many of the people we look at today that we are put in a position to resuscitate in the emergency department and in the field don't look just like us anymore, and they're profoundly at the end of life. The reality is that somebody with advanced tuberculosis, dying of a pneumonia, or otherwise profoundly ill would not have been resuscitated until just the modern age. Sorry, Chris. When you look at the way these resuscitation societies suggested performing resuscitation, some of these things were pretty reasonable. The idea of inverting a victim, turning them upside down, and even shaking them a little bit is kind of an interesting idea. Putting a victim on a rolling barrel is another one. But if you think about putting a victim on a trotting horse and basically having them go up and down like this on the back of that trotting horse, frankly, that's mechanical CPR. I've actually talked about the idea of getting trotting horses in our emergency department to do mechanical CPR on some of our patients. Oddly enough, it was the ESAs or the custodial staff that had the biggest problem with that intervention, although frankly I think it would have been an interesting twist. In the 1500s, they actually used bellows to blow air into the mouth of a victim. That's because the blacksmith was frequently front and center on anything that was happening in the middle of town. And frankly, warm air as the breath of life is a reasonable concept. And we still use a BVM today, which is basically a bellows, but a lot less interesting to appear. And then when tobacco got its way to the old world from the new world in the 16 and 1700s, tobacco smoke was used as medical therapy. It's not such an crazy idea if you think about the idea of nicotine as a stimulant being used in a case of cardiac arrest resuscitation. And frankly, today, the idea of blowing smoke up someone's ass persists in much of medical therapy. Sorry. So they continue to use different types of manual ventilation and all sorts of other things to try to make people live when they seem to be dead. Tongue stretching, rectal stretching, rubbing the body, tickling the throat, ammonia salts, which frankly I think some less active people still do today, and cruel people will still take ammonia salts and jam them into people's noses. Actually saw one sitting in my dentist's office yesterday. He's got it taped to the wall there. And it's a good way to obnoxiously wake somebody up, but it's not a very good technique of resuscitation. Beating victims isn't something that's done often, although some of us will continue to do precordial thump on patients who die right in front of us. Frankly, I think that's more to get out our frustration on the fact that these patients decided to go into a fatal dysrhythmia rather than anything that's truly evidence-based. Then we got to the 1940s, and open cardiac massage and open defibrillation was used. The first open defibrillation was actually done using a test using a trial box that hadn't even been formally approved in the hospital yet on a child who had went into fibrillation on an operating table, and the child survived. In the late 50s, Peter Safar experimented with mouth-to-mouth. The next thing you know, Dr. Kuenhoven, Safar, and others all introduced the idea of closed chest massage. And in the 60s, CPR and really advanced cardiac resuscitation was born. Since then, we've continued to develop around the same ideas, but really we haven't gotten that much farther. Now, there's a lot of different situations that we just don't know what to deal with yet. And I think that's important. One is mechanical compressions. If we can keep blood circulating for long periods of time, how do we ultimately adjudicate when somebody is truly dead? We had a fascinating case here recently where when we put a mechanical CPR device onto a patient, they actually reached up to grab the plunger. We'd turn the machine off, and the patient actually was still in ventricular fibrillation, which we could not break. Working with cardiology, the patient ultimately ended up dying. But when this patient was early in their arrest with mechanical CPR in place, they were perfusing very well. So it's hard to tell exactly when you end a cardiac arrest and mechanical compressions are in place. Another would be, what about ECMO? Certainly we're seeing ECMO being used out west. We're seeing ECMO being used in the Far East. But the question is, who is viable and how do we make that decision on who is viable and who should get this extremely expensive and difficult to impose technology? That's something that we're going to need to develop more ethical and really moral decisions around. What about taking a patient to the cath lab and arrest? I think that actually may have been a great move for our patient that I mentioned in mechanical CPR. However, that's not always something that's available. And in New York State, frankly, in many cases, our interventionalists are going to be precluded from taking patients to the cath lab because that would still be a reportable death if it occurred in their cath lab while they were performing a procedure, even though that patient was in cardiac arrest when they went to the lab. Mm-hmm. That's something we need to work on with the Department of Health and around the regulations that have to do with public reporting. Cases of organ donation. Should patients be brought with mechanical compressions in place to the hospital for harvest for organ donation? And should we be using mechanical compressions to continue to keep people perfusing their organs so that we can decrease the total amount of organs that are required out there? This is something that's done in Spain very successfully. They have a number of papers that they've published around the idea of organ donation following mechanical compressions. We have a case that we did in Albany that we're in the process of writing about, which we did mechanical compressions for 4 hours prior to successfully harvesting 2 kidneys from a patient who had been shot and ultimately died. It's difficult to decide where organ donation fits into all of this. As a disclaimer here, I do sit on the board of directors of the Center for Donation and Transplant, so I do, I suppose, have a conflict here. But since this is all about good patient care and ultimately care of a population of patients, I don't find that this is a unsurmountable conflict. What about assisted suicide? That's a fascinating question for all of us in medicine right now. Assisted suicide is a topic of conversation out in California where it's just been made the law. There are several different assisted suicide or facilitated death bills that are pending in different areas of the country. And ultimately what that means to physicians and then EMS providers treating patients, I'm not sure. And I don't think morally we've gotten anywhere near that yet. But it's a fascinating concept for a patient to be able to die on their terms with their schedule in mind. And last and the most important situation of all of these is hysterical families. So let's move on from here quickly. Oh, sorry. Let's not move on. Let's focus on billing for a second. We have to do this. And the reason we have to do this is the idea about when you terminate a cardiac arrest should never be based on billing considerations. But I think for everybody out there that has decided the idea that we should just pronounce patients in the field, move on, and not worry about whether or not the person who counts the shekels is going to have anything to do with wondering whether or not they can get paid, they're wrong. We need to make sure that there are billing processes in place so we can optimally care for our patients, care for families, and not transport patients where we're not going to get any meaningful return. Sorry. So now what do we think about from here? What else do we need to consider? There are a lot of other things that are going to be profoundly important when it comes to looking at end-of-life issues. In particular, deciding factors that we need to think about. Well, we really need to think about what patients want. Then we need to actually think about what do families want. We need to go from there and also consider what's going to work well for our EMS providers and what's going to be safe. If families have lots of guns in the house, it may be difficult to actually say grandma's dead. But what we need to make sure is that we've thought through that situation. We also need to think through what we want and how we've trained our personnel. Do we want to take patients that are non-viable to the hospital? I don't think so. I think at all times, EMS providers are looking to make sure that what we can do is optimally care for our patients, care for our families, and then move on to our next patient care scenario, hopefully feeling positive about the scenario that we've just left. Something that we have not done at this point, ultimately, is address the idea of first doing no harm and doing what is most medically indicated. How do we make sure that we are appropriately caring for our patients? How do we make sure that we're not causing additional problems for a medical system, for families, or for each other by caring for patients at the end of life? So in a study that was done back in 1994, they started looking at whether or not old people, right, this is the very old, who'd want to undergo CPR at all if they had a cardiac arrest. Really, at the time, no one had looked at that. And unfortunately, because we make the assumption that it's a good idea to do CPR for everybody, we just do it. But is this really the right answer? At the time, nobody had really looked at this. So in this case, they just went out and they asked older patients in one geriatric practice whether or not they thought it was a good idea to get CPR. In this practice, they looked at 371 patients over the age of 60. As they did that, they found out that about 287 participated, and 41% thought CPR was a good idea. But once they started learning about the survival to discharge, and that survival to discharge was probably 10 to 17%, which all of us would probably agree was vastly inflated, the number of patients opting for CPR plummeted by 50%. In fact, of the patients 86 years or older, only 6% of those patients wanted CPR. And interestingly, when you start talking about patients who have chronic illnesses, that life expectancy was going to be less than a year. 11% of those patients opted for CPR. So at the end of the day, very few people, when they truly get a meaningful understanding of what the probability of CPR survival is, ultimately ask for CPR to be performed on them. So, Chris, that's actually going to happen, I think, with a couple of these different slides.
Okay.
So what do families want? Well, this is important here to realize as to whether or not family members can accept field termination. This is something that our providers are really concerned about. And frankly, as a medical director, I am too. I want to make sure that our families are going to be satisfied with the results of a termination in the field and make sure that that's going to leave patients comfort. Now, what Chris and I did when we were in the field in Pittsburgh is we would very frequently terminate cardiac arrests in the field. But that's almost cheating in the city of Pittsburgh, because there you have a physician at the bedside for those cardiac arrests, having a conversation with the family about exactly what's going on and exactly why there is no additional efforts to be brought by transporting that patient to the hospital. In this case, this was Ted Delbridge, who Chris mentioned earlier. In this case, they interviewed everybody in a structured manner following a resuscitation. During this period, Those doctors went to 140 out-of-hospital cardiac arrests. We followed up with family members in a significant number of those. 96% of the families actually reported satisfaction with the decision to terminate in the field. Of the cases that were transported to the hospital, 82% of those reported satisfaction with that transport. It's interesting that that's lower. As we go on from that, that's even more interesting, is of the ones that were terminated in ED ultimately, there was an expectation. Sorry, here come our little red circles again. All right, 76% of the patients who were transported might have accepted termination in the home because there ultimately wasn't a different outcome when that patient was transported to the hospital. I think that's really important to recognize, is that family members will accept the termination of an unsuccessful resuscitation in the field. We just have to give our paramedics the skill set in order to make sure that they can have that conversation with the patients. Something that's important for us to remember is that the termination rules that have actually been developed by the ROC Consortium and are both referenced here ultimately show that these ALS rules have 100% sensitivity and specificity. If a cardiac arrest isn't witnessed by EMS and there's never been a defibrillation, never been any ROSC, the event wasn't witnessed in the first place, there's been no bystander CPR, these patients will stay dead. Ultimately, we need to make sure these patients stay dead. We've seen more than one case where EMS providers have gone to the scene, have pronounced somebody, and then ultimately the patient is woken up in a body bag, woken up in a morgue, or woken up for law enforcement. There was one of those just a few weeks ago in the city of New York. The reality is that nobody who works in a morgue actually wants to meet live people, so it's very troubling for them. It makes EMS systems look really bad, and the bottom line is it's bad care. If we're going to say that somebody is dead, we need to be right. We need to be right. So ultimately, how well prepared are we for our EMS personnel to do this? And actually, Brian Clemency and the team out in Buffalo has done some work on this. And if any of them are on the call, I know Brian can't make it. He's actually in Europe right now. But it's important to recognize that there really isn't an assessment tool to look at pre-hospital personnel and their understanding of end-of-life issues. So as the team out in Buffalo started to put together some of the ideas behind this, they just started asking questions and interviewing people, and then interviewing other groups of EMS providers under different settings. And they found out that 93% of our EMS personnel are ultimately comfortable with DNR orders. And 87% are comfortable with the most. Most are also comfortable sorting out conflict between patients and families. And they said that 92% of them had formal training about DNR orders. That's really important. I wonder about that other 8%, and I'm thinking that maybe the same as the group that were comfortable with DNR orders had formal training in DNR. And I'm a little bit troubled that 13% aren't comfortable with most. But as I look around my emergency department, I see physicians that talk to people about most that aren't particularly comfortable with the most, because sometimes it becomes a complicated document, and it really shouldn't be. So ideas on how to improve EMS understanding, ultimately we can improve EMS CME and the initial education. If we really only have about 56% of EMS providers who are getting initially educated to the idea of MOLST and end-of-life issues, we need to fix that initial education. But remember, most EMS education is actually revolving around the idea of saving lives. So the concept of actually allowing somebody to die in peace or allow a natural death, which is a term that I much prefer to DNR, is actually difficult to build into that training and is never going to be a huge component of that training. On the other hand, the idea of DTRT, which is do the right thing, and focusing on the patient and what their ultimate outcome is going to be, can be a part of initial education. Among the things that providers said would help was also to improve healthcare provider education. So this is other providers from other walks of life, including staff in nursing homes so they understand more about what the paperwork in a patient's chart is, or primary care physicians and oncologists. I think that's a frustration that most emergency physicians have as well. Also, the idea of improving public education around end of life. The idea that people, when they die, well, maybe EMS isn't the right phone call, but 911 right now is the sole response for people who are in crisis. We need to make sure that we do a good job of what we're going to bring to the patient when we get there. We need to make sure that the family themselves know what the wishes of their patient, of their family member is, so that then they can carry that forward to assuring that they can support us as we take care of the patient. Something we need across all of EMS that would be valuable in end-of-life issues, but that's also valuable in many other situations that we face, is improving conflict resolution skills. That's not something that only becomes an issue and is only helpful in end-of-life situations. We face conflict frequently in EMS. Luckily, we're not facing the types of assaults associated with conflicts that they are in the UK, but certainly that is a potential that we have to face down the line. We also need to be much better at improving training to handle emotional families, how to decompress those situations and make sure that everybody's focusing on the care of the patient, and then everybody is being supportive together for a family in crisis. And then something that hopefully we're going to work on in the collaborative group is making our protocols more clear. We want to make sure that EMS providers have the opportunity to terminate resuscitation when it's appropriate, to activate care for end-of-life issues as they're being demonstrated to us, and at the end of the day, we're giving the best care we can to our patients. So we start caring for the family when the patient is no longer the patient. That's really what we need to focus on at the end of life. Once we've looked at the case and we know that there's nothing else that we can do for that patient, now our patient is the family. Among the things that the folks out in Buffalo looked at as they started questioning is, how do we actually need to handle an emergency end-of-life call? The first thing is you get to the scene and you're going to assess the patient, then the event, the family, the scene, and the environment. Then what's going to develop into that process are family responses and conflicts. You're going to find things that you've never found before as you get into these end-of-life situations. And then ultimately, the management is going to be interventions for the family and the patient, depending on each situation, and each situation is going to be profoundly different. It's notable that this paper is entitled, "We Are Strangers Walking Into Their Life-Changing Event," and I think, frankly, that is a fantastic title for this situation, because that's exactly what we are and how we have to respond. So the family itself, regardless of what the situation ultimately is, the loss of a family member or friend is hard to deal with. And now we need to recognize that we need to communicate with the people that are left behind in order to make sure that we can transition care effectively. We need to recognize, walking right in the door, that there are going to be cultural and educational differences between us and the people that are there. In some cases, there are going to be easy things that we need to try to understand. There are going to be some things that we are always going to have difficulty with. But we need to actually focus on how to take our paramedics, how to take our EMTs, and how to help build the confidence and interpersonal skills that they need in order to be able to deal with these situations. So Sherry Hobgood did a fantastic job of putting a program together called Death in the Field, teaching paramedics to deliver effective death notifications. This is the grieving evaluation. This is something that, frankly, has changed the way that we should be teaching our paramedics and our EMS providers across the board to deal with death. Because what it does is it allows people to learn how to do notifications and then how to handle that situation where they're now caring for a family. They looked at confidence, confidence, competency, and communication, and then started to look at this essential criteria to understand how to build a good death notification. The most important thing, and this is the single most important thing that I think most of us in the emergency department have realized over time, and we're starting to encourage, to build into our resident training, is to get as many of the family members present before we start talking about what's going on as possible. Introduce yourself. Give the type of background that you bring to that situation. And then find out who everybody in the room is. Because this way we can make sure that we're speaking with the right people and talking to them and addressing them correctly. When you can, don't do a notification alone. In the emergency department, most of us will go with our charge nurse or another nurse who's cared for the patient when we can. In the field, frankly, one of the best people to have would be a law enforcement officer if they're present. Try to do this in a private place. Get everybody to sit down. And if you can sit down with them, do that. It makes a huge difference in terms of having this conversation. Among the things that are most important about this conversation, be direct. After you have the right conversations about who's in the room, all right, and an understanding that you need, if there's any additional information that you need, get that first. And then you can say that Mr. Smith has died in spite of your best efforts. Always use the word died or use the word dead. Don't use the word don't start talking about he's been a better place. We don't know him that well. Maybe he's not. All right, and that depends on your own religion and your own ideas. Tell the family everything you can about the patient's condition, what happened. Tell them exactly what you think occurred, but don't speculate. All right, so don't make up the causes of death. Listen, answer questions. All right, try to be at eye level if you can. All right, you can touch, all right, but don't initiate hugs. All right, and discuss what's going to happen after that. Offer to help make phone calls. Just you making a phone call to the primary care physician of an elderly person can make a profound difference ultimately in how that spouse is going to look back on that case. All right. Right now, you are making a huge impression for your agency, for yourself, and frankly, how that person is going to remember those last few minutes of their loved one's life. In a lot of termination situations, law enforcement stays. In some cases, the ME will take the patient or the body. In some cases, they won't. Most of these will be determined based on a conversation, if it is a natural death, all right, that you have with the primary care physician if you can make that phone call. I can't say enough from the perspective of the primary care physicians I've spoken to about how much they appreciate a phone call from the paramedic or a physician on the scene at the time of a termination or resuscitation. It makes a huge difference for that primary care physician. Things that you might see, and we see these in the emergency department as well, you may see anything from crying and anger and hostility to disbelief, guilt, playing, hysteria. You may just see fear. Any of these things is entirely possible. The one that's probably the most troubling is the blank stare where someone says nothing. That's really hard to understand how to react to. We just need to try. Things that help. I'm sorry for your loss. How can I help? It's normal for you to react this way. It's harder than most people think. I know this is painful or hard to accept. Basically, this is your chance to react as a human being. And recognize that all of these are phrases that are just going to come from you because you're human. And it's an opportunity for the humanity really to persist throughout the situation. Things that are profoundly unhelpful, never make assumptions about how someone should feel. All right? At least you're lucky. You're lucky that now they're in a better place. Right? You have to focus on the good memories. You don't know that either. Right? I know how you feel. My cat died recently, right? You need to actually recognize that we have to be helpful when we can and not make any assumptions. While we can be supportive and empathic, what we can't be is we can't understand exactly what the relationships in front of us are. So just try to be as supportive as possible. So Sharon and Edwardson and Davis did this at Rochester, where they looked at 33 asystolic cases where they terminated 21 of them in the field to see whether or not this would be supportive. And what they ultimately found out is that EMS was really good at doing that job back in 2002. And this isn't, frankly, something that's gotten worse over that time. I think, frankly, we're getting much better at it. We need to get better at it because we're going to keep on doing this. So how do you ultimately decide when to make this decision? Well, ultimately, what I like to make sure is happening is good communication, both between the providers and the family. Any resuscitation, be it in the emergency department or in a house, needs to have a discussion between the providers and the family throughout. It needs to be a good discussion. They need to know exactly what's going on. Frankly, anytime you're putting that much effort into care of an individual, you should really have a good conversation about what exactly you're doing. In the emergency departments, I don't know if everybody else is practicing this way, but I try to have family in the room for resuscitations when possible. Because if they see how hard we're working, ultimately I think it gives them some peace. And that's something that I think goes a long way for someone to work their way through their sadness and recognize that everything that could have been done was done. We need to remember that this is always going to be difficult. If we're not going to transport the patient, we have to recognize that sometimes families will have a false sense of hope that the hospital can do more. We need to make sure that that goes away. Frankly, that's something where in a termination, a conversation with a field physician or the physician in the emergency department can make the biggest difference, because the physicians can talk their way through exactly what would be done or wouldn't be done in the emergency department. The sooner patients know or the families know that this is going to occur, right, the better it will ultimately go. And having medical control involved all the way is completely important. And as medical control physicians, what we need to do is we need to be prepared to take these calls, have conversations with family members. Frankly, I think in all of these, just like most other medical control situations, if you're not having these conversations on recorded lines, both for quality assurance and review personally, you should probably find a way to build that in. I know there are a significant number of places where they don't use recorded lines for these conversations. They take the opportunity for you to learn from these conversations away, and I think we should all push for that. What we know is that cardiac arrest is going to be one right then and there, and it should really only be safely treated and secured. It should be either treated on the scene or secured on the scene. And then we should teach people a good job on how to stop resuscitation in the field. I think most of us are all on that page already. But now, let's take this the next step. The word patient ultimately comes from the Latin patur, which is one who suffers. Now, there are a lot of different ways to think about this, but ultimately, the one who suffers is probably a good way to think about somebody at the end of life. We know how much money and resources are spent on patients in the last few months of their life, and we need to focus on that and think about one who suffers and whether that's how we actually want to drive care. If you haven't read the essay by Ken Murray on how doctors die, you should. Google it today and read it, because doctors don't die in ICUs. Doctors with long-standing medical conditions die with their families. They die in places of comfort to them, and they die with their families at their side. We should probably be able at this point to start to drive medical care so we're taking care of patients the way we want to be taken care of. Mm-hmm. There's a gentleman by the name of B.J. Miller who I recommend that anybody who's listening to this podcast right now go and listen to his TED Talks. Dr. Miller is a palliative care physician out in San Francisco. When he was a college student. He climbed on top of a train and grabbed a hold of the electrical elements of that train and spent years getting operations and time in ICU because of the profound injuries he suffered. Now he practices palliative medicine in order to make people more comfortable throughout all of their life, in particular towards the end of their life. And what he focuses on here is that medicine really is designed around diseases and not people. And that's wrong, because it actually violates the first premise of Hippocrates, which is first do no harm. We need to take care of people. So Chris, if we can we make that work?
Let me try.
Okay. So this is actually what we call...
This is Andrew.
Hi, can I have a remote position, please?
I'm sorry, remote position 308. Go ahead.
Hi, I'm at a residence with an elderly female. How old is she, ma'am? 79-year-old female who's she's got a DNR. She's got COPD, CHF, multiple other issues, but she's full with failure. And her daughter says they've discussed it. She does not want to go to the hospital at all. We were going to put the CPAP on her and transport her, and the daughter says she absolutely doesn't want her to go to the hospital. So, what now?
Okay. Why were you guys? Who called you? Why were you called? And
The daughter
tell me a little bit about how
called us.
the patient's presenting.
She's unconscious, unresponsive. Daughter tried to call the hospital. She hasn't really been responsible for 4 this morning. She checked her at 4. She wasn't really awfully responsive, but she was answering her then, and is not now. She's struggling to breathe. She's on Homo 2.
So that case is an interesting one. And frankly, my resident took that case, took the call, spent about 30 seconds or so on the call with the paramedic, and immediately went for the attending. The attending heard about 30 seconds of it and called me. It's a fascinating question. What do we do as EMS physicians when we are faced with somebody who's gone home, is now in some respiratory distress, has some secretions, and they're requesting care, but they don't have any medications set up through hospice yet, and now we've got a paramedic at the scene? How do we start to handle that? I think each one of us will handle it a little bit differently. I actually had a conversation with the daughter myself. I was very glad that we had a grown-up paramedic on the scene, someone who'd been doing this for a long time and long enough to be able to understand that she was caring for the daughter as much as she was caring for the mother, and that this was a daughter who really wanted to support her mother through her wish to allow a natural death and stay at home. And what we ended up doing was giving a very, very small dose of atropine to dry her secretions, a very small dose of morphine in order to give her mother a little bit of comfort, and they stayed together at the house until Mom died. That's not something you'll be able to do with every paramedic. It's not something you'll be able to do in every situation. But in this case, we had a patient who wanted to die at home without any additional preventative intervention because she had been through so much of this already, she didn't want any more. In fact, she'd actually been discharged from the hospital within the last 24 hours. Hospice was supposed to come to the house within the next 24 hours, and she deteriorated prior to their arrival. Ultimately, this ended up being an excellent example of good quality patient care. But each one of these is going to be different. I think we can protocolize some things, but I'm not sure we'll ever be able to protocolize anything other than a guide to how you can start to appreciate these situations. I don't think it'll be able to be driven without a physician very involved in that case. If you're not using a MOLST in your practice, please start. If you have an opportunity to support a move towards eMOLST or the electronic MOLST registry, please do. I think that EMS and emergency medicine has more to gain from a proliferation of electronic records of quality wishes on behalf of the patient than just about anything else. The old pre-hospital DNR order really was very, very limiting. The current MOLST, to be quite frank, is a difficult document to navigate. It doesn't make sense that Section B is actually the signature for Section A, and it shouldn't be so hard to pull out the fact that somebody wants to be resuscitated from this document. It should be more clear. But reading these documents is going to be the best thing that we can do to ultimately end up guiding care for the patient. And having our paramedics and our EMTs able to read these in a cogent fashion and then pass that information on to us is going to be clear and convincing evidence of how a patient wants to be cared for. So the MOLSTs themselves, and this is actually taken from the MOLST training. It was written for EMS and first responders, is available actually on the website. Does provide very explicit directions on how CPR, mechanical intervention, and other life-sustaining treatments should be done. It should be reviewed by with the patient every time they interact with healthcare providers, and should actually be documentation of a lengthy discussion with that patient. This is something that primary care physicians and emergency physicians, frankly, can now bill for. Whether or not everybody will get paid for it, that I can't say. But it's certainly something that's helpful. And it, more than anything else, it's clear and convincing evidence of what that patient's wishes are. We need to know and teach our paramedics and EMS providers what a MOLST is, what a non-hospital DNR is, and ultimately that either order can still be nullified, although a MOLST really should not be if possible. Ultimately, this is going to be a question of conflict resolution. At the time of an end-of-life situation involving a family, let's face it, we're not going to end up having long discussions at that point and battles over exactly what the legal requirements of those forms are when we've got a couple of paramedics or EMTs on scene with a patient and we've got a family that disagrees with what's written on the form. That's not a time that we're going to be able to adequately adjudicate that situation. What we're going to need to do is try to do some conflict resolution and make sure that we're handling the situation as safely as possible for our crews. Proxies themselves, all right, these document an agent, all right, that agent themselves, right, can make decisions for their patient, all right. That's important for us to remember when we're talking to proxies on the phone, when we're talking to proxies in the emergency department. Okay? Sometimes proxies have a guide like this, which can actually help understand what types of things are going to be helpful. On the other hand, sometimes a healthcare proxy is just going to say, I hereby appoint Chris Knutson to be my healthcare proxy, and have no guide whatsoever in terms of what I want Chris to do. By the way, I've actually made my wife my proxy, so Chris, you're off the hook.
God.
I think it's really important for us to recognize that what we face with all of these documents is an opportunity to look at the state of the art in end-of-life care and making sure that our patients are dying with dignity when there's nothing we can do to stop this. Living wills, all right, if anything, actually become confounding. So living wills are non-standardized, are written by lawyers, and very frequently will have very little that will actually pertain to the care of the patient at the time that you're caring for them. It does give you some helpful material to start discussions with families on, but unfortunately it doesn't really carry it through the way we'd like. Here's one of the copies of the living will on the next slide that basically just shows what it looks like. Unfortunately, it causes physicians some angst because it doesn't always give us as much information as we'd like, because it's difficult for us to say what is an incurable or irreversible mental or physical condition with no reasonable expectation of recovery. I don't know what that always means. So ultimately, B.J. Miller said that we should redesign and rethink how people die. Frankly, I think that EMS is positioned better than any others to make sure that our care is delivered with compassion and making sure that we focus on our patients first. We are in a position as leaders in EMS medicine to make sure that this occurs. We not only have to be experts at resuscitation, we ultimately have to be experts at saying no. So a couple of acknowledgments that I really want to make sure that we make clear. Pat Bomba is the medical director for geriatrics and the statewide champion of the MOLS program here in New York. Pat has been huge in terms of making sure that end-of-life wishes are a focus not only of the Department of Health, but also of the payers. Because while it's sad to be focused on money, if we don't focus on how the money is going to flow, we won't have primary care physicians, oncologists, and other physicians that care for patients on an extended basis work on end-of-life issues that are profoundly important. Jeremy Cushman, as always, has been incredibly helpful. Many of these slides were developed with him, and frankly, the slide deck that we use across the I-90 corridor should always be something that basically is a sourdough phenomenon where you take a little bit down, you put your own in, and then you move it along so other people can use it as necessary. And then some other thank yous as well. What I'd like you to do is talk about your own mortality and teach about your own mortality. Make sure that that you have the opportunity to have these conversations with your family, your loved ones, and your colleagues. We all have the potential to be in a position to have to work with our colleagues in these situations. Now, somebody that I do want you to watch that originally I had in this talk is the Z-Dog MD special presentation on end-of-life issues. Normally, Z-Dog is hilarious. This one is just very, very thoughtful. And it's called It's Not the Way to Die. Please watch it. Watch it with your spouse. It's a good idea to make sure that they know your wishes and can get a better sense of where we are. The next phase of resuscitation medicine is going to be the most important one. And this is where we actually take resuscitation medicine and we allow the morality and ethics of medicine to catch up with where we are with the science of medicine. We need to make sure that as EMS physicians, we're not going to stop resuscitating somebody until it's time to stop. But we need to be the people who can figure out when to say enough is enough and when to stop a resuscitation because it's ultimately futile. And that, folks, is what I've got for you. I hope this made you think. I hope it gave you an opportunity to consider, hopefully not your own mortality too much, but how you're going to work with your paramedics and EMTs. And I think it's giving us all another opportunity to recognize that we've got more teaching to do. And we've got a lot more learning to do as well, because we've got our EMS providers on the front lines of end-of-life issues all the time. And we need to make sure to give them as much skills as we can in order to be able to care for our patients as well as they possibly can. So thank you very much.
Thank you, Mike. That was really good. I had two questions, if I could ask.
Please.
For transport, I guess I haven't seen any literature on this. When EMS agencies transport their cardiac arrests, do we know why they do? Are they doing it because they think it's better care? They don't want to deal with the people on scene, they think it's the right thing to do for the patient? Or do we not know? Or are all those reasons true depending on the agency?
I think, Chris, it's one of those things where there's so much variability in terms of practice between regions that I'm not sure we'd be able to get a paper that would really be cogent or reasonable out of it. But if we were to take a few different sites, say the I-90 corridor, for example, I think we may be able to at least start to put some ideas together to look at those cases.
Yeah.
I think there are some situations, at least locally here, where providers think maybe there's something else that can be done that I'm not doing. There may be some, like the unfortunate patient that my paramedics took care of a couple of weeks ago, who was reaching up and grabbing the plunger on the thumper. That's not a guy who's ready to give up. They weren't ready to give up on him.
Yeah.
On the other hand, they were transporting him with mechanical CPR in place. So, frankly, they could have brought him to Syracuse, with that plunger just still going, and it wouldn't have changed how that was. It wouldn't have increased the amount of hazard to him or to the crew.
Yeah.
There may be some situations where they're getting away from family. There may be some situations where they don't feel comfortable terminating. Each situation, I think, that I see is different.
Yeah. And I was curious about you said we could bill for going over the most. Is that I think I saw those codes recently. Is that part of, what is it, care planning? Or is there a different billing code that you know of?
I don't know.
Okay.
One of the advantages of being part of the physician practice is I don't have to remember the billing codes.
Yeah, fair enough.
which, frankly, I really enjoy. The primary care physicians and their office managers, I'm sure, know that very well.
Not one that I've seen before. I was just curious. So.
Yeah. And the other question is, just because there's a billing code doesn't necessarily mean that it's going to be paid.
Correct.
The thing that, of course, is most true for all of us in EMS is the fact that there is a billing code for doing pre-hospital medical direction.
Yeah.
But there's never been a payer that's been found that pays it.
I'm going to unmute everyone else. I don't know if anyone has a question for Mike.
Yeah.
Or if not, I'm going to say thank you.
Hey, Doc, I got one for you.
It's Tom Dorn from Syracuse Fire.
Yeah, Tom.
Hey, Doc, so when you go through school and you're learning to be a paramedic, you're taught, you go in, you take control of the scene, you're going to save this life. That's your job. That's why you're there.
Exactly.
How do we get our guys to buy into saying, all right, now it's time to stop?
I think it's one of those things where you have to recognize what the limitations are. I think the reality, Tom, is that, you do interior attack on a building until you recognize there's too much of a hazard in order to do it anymore, and then you back out. While there's not as much of a hazard in a transport of a cardiac arrest to the hospital, the reality is there is still a significant hazard because you're putting not only the patient but your team into an ambulance that's now going to be driving along while you can't be secured anymore. Moving somebody down a set of stairs during a cardiac arrest resuscitation is another opportunity for a life-ending injury, a career-ending injury, certainly for our providers. Little different than having a ceiling come down on you, but no less career-ending. I think we need to focus on the idea of what is the return on the investment. Now, I don't know if this is something that we initially teach or just mention for those people going through class the first time, or whether this is a part of their first set of continuing medical education after that's done. Because, frankly, I agree with you. It's a full court press until we determine it's not. And I don't think that in any case we should ever approach a cardiac arrest with anything less than that. We should respond to every cardiac arrest as we can save him until we get clear and convincing evidence that we're wrong.
Yeah, thanks for that, Doc. I found this very interesting. I'd love to be able to use this and share this with all my guys at Syracuse Fire.
Please feel free.
Thank you.
Anyone else? Going once? All right. I want to thank Mike Dailey again. I think this is a difficult but hugely important topic. I'm sure we can all acknowledge that. And I thank you for bringing some lessons learned and some insight into this that we can all share with our folks in our agencies and in our fellowships. So thank you to Mike.
Great.
And,
thanks, Chris.
Of course, next month is Kevin Munchal is doing mobile integrated healthcare. We'll be on the third Tuesday because of the holiday, not the last Tuesday. And we'll set out a link as we get closer as well. So until next month, thank you for being a part of this.